To that question, so there's the depends factor in the whole, do I believe in things? Well, I mean, I can show you my outcomes. When people come to me, and I have this on my Facebook for my patients, this is what I can offer you. And every person offers different things depending on experience and so forth.
So if I test you and ask you, between two surgeons of equal skill in their respective techniques, which method would you prefer?
Well, I think the proof is in the pudding. I mean, if this was a hype in the States, I don't think 92% of prostatectomies done today are being done robotically. So 92% of anyone with prostate cancer going for surgery in the States are done robotically. There's no question there's a superiority. So one of the benefits, and I'll show you some of my data shortly, but I don't want to, for the purpose of this talk, jumps over the kind of the purpose of what we're trying to talk about. But with regards to outcomes, I think that's highly relative to your skill set and your experience. My anastomosis, what I consider, you guys have ever seen that gap between the bladder and the urethra? Because the prostate comes out, there's, I don't know, that last video you can see there was a gap. That bladder comes down and is reattached. In open surgery, they put 4, maybe 5 sutures, interrupted. I put 25 baseball stitches, and I removed the catheter 4 days, not 14 days. My likelihood of bladder neck contracture or urinary leakage is about 10-fold less than open surgery. My patients go home within 24 hours. My oncological outcomes are similar or better to the standard in Canada. But again, I've done 1,200 of these, so it's hard to say. It all depends. So it all, when you ask specific questions like that, these are things on an individual basis that I'll go with people. Other questions?
Is there a pattern or a certain growth rate at which cancers spread? Because I get checked once a year.
Right.
I assume that's enough, that if you catch it next year, it's still really enough to do something about it.
So I can answer, that's a great question of the rapidity of prostate cancers. Unfortunately, we don't have that, the police radar, but that's going fast. I think that's what we need, what we call biomarkers with this PCA3 and other things that we can say, well, this is Gleason 6, but it has this mutation, and this is known to grow faster. We don't, aside from doing serial biopsies, which again has the pros and cons, is we're also sampling, there's also sampling error factors. But there's no way of determining that. But what we do know is that people from wait times from surgeries, I've had some people wait 6 months, 7 months. And there's actually 2 huge theories that says people from the time of biopsy, time of surgery, can wait up to 6 to 8 months. The half-life of most cancers are about 6 to 7 months. So we're not talking about something, and that's something when people get the cancer, when did this likely start? Probably a couple of years ago. It doesn't sort of grow and just blow like landfire. That also goes to answer indirectly your question. Well, if you go to Laurie Klotz in Toronto, he's kind of the grandmaster of that active surveillance. So he has a huge series of people, and you can PubMed him and look him up. And he has people with Gleason 6 being followed for up to 5-7 years now, and about only 20 to 25% of those patients will move on to have surgery, and there's been no mortality. There has been people who've had biochemical recurrence, but no one's died in that series. So we're talking about life expectancy. There's also a paper, again, trying to think of how to answer your question indirectly, something called the Pound paper that we read about in residency that was in the 1990s, that those who had recurrence after surgery, they weren't treated. They had surgery, but the cells it took about 11 years before they developed bone metastases and 13 years before they died. So most people, I tell them when you get the diagnosis, the decision we're making today is probably going to affect how you're going to live 10 years from now. And then I try and direct their focus. You're smoking, you're not exercising. What's the number one cause? We're sitting here talking about prostate cancer. 6% of men with prostate cancer men will only die of their disease. What's the number one cause of human death? Heart disease. So what are you doing to lower your cholesterol, watch your blood pressure? That's what's going to put you in the casket, not necessarily this. So this is when I discuss with people a life-altering event, not a life-terminating event. So you have to look at everything in perspective, and these are one thing that I like to sort of then take the time so that people are starting to exercise, do things that's going to make you live longer. Because this is not what's going to hurt in the long run.
Is this the same machine that Montreal General uses for complete hysterectomies?
Yes, so actually the number in the United States, one of the biggest users now are gynecologists doing radical hysterectomies. So the Montreal General, the Jewish is actually I work with him indirectly for some research project. Dr. Walter Gottlieb is kind of the most experienced Canadian gynecologist using it. He's at the Jewish, and they're actually getting a second robot soon. But But I don't know I know the general has one. I believe urology, and I'm not really sure if gynae's, but in Montreal, 22 robots, Montreal General, Jewish General, St. Luc, Sacré-Cœur. So help me out with my math. I haven't eaten dinner, but that's, about 20%, I guess, of Canadian robots are here in Montreal. So I guess we're fortunate that.
How long does it take you to do a remove the prostate?
So, again, not to for speed and rapidity, but I've got some guys who come in and their BMI is like 19. They look like they're like an athlete. And someone vocal about it actually, he wasn't the fastest, but he was quick, he's a Canadian national swimmer. He's living in New Zealand now. He made a whole thing about it and brought up his story. Alex Bauman, so he's one of the patients I got to treat last year actually. And his surgery was about an hour and 20 minutes. And sometimes people who are obese and other previous surgery have taken me up to sometimes 3 hours, 3.5. But my average time is about just under 2 hours, skin to skin. With a blood loss, my average blood loss is about 170 milliliters. My average hospital stay is about 1.1 days. So it's really changed the way, when people have gone and had radical prostates. Unfortunately, when I first started doing this at St. Luc, I work with 15 urologists, and there are certain beds that are saved. Unfortunately, one of the first patients I did earlier this year, he was a 60-something-year-old guy, and his next-door neighbor was late 40s, and they both wake up. We both did surgery the same day, and he looked over. And we've changed this since then, but unfortunately, there was a whole, the other guy got, a little mad. He's like, well, why wasn't I offered that surgery? Well, his surgeon didn't refer him to me or didn't know how to do this, but he did the right surgery, he did a radical prostatectomy, but he stayed in the hospital for 4 days. My guy was, checking out the next day, had his catheter out 4 days. The other guy had to go to the CLSC to take out staples and a catheter in 14 days. So that's I don't know. I have another one. I'm not sure if it's making its way back there, but I did bring two. Thinking, I don't know if you guys want to pass it to the back. If anyone wants to see the instrument, I see it being passed back. But if you guys want to pass it back, kind of beyond those. I don't know. Any other questions regarding?
If you have this active surveillance and you have annual biopsies, what's the downside of that in terms of damage to the prostate from constant nibbling away at it?
That's, we always ask that question. Whenever I've had, some of my patients have been, a third biopsy shows the upgrade and they've moved towards surgery. I've had patients where they've had multiple biopsies and that plane for nerve sparing is really nice. And sometimes you get there and it's more thick. It's not as easy of a nerve sparing. So the nerve sparing, the way I look at it and I explain this to people, it's like when you take a tangerine, you take off the rind. Well, that's a tough, not always easy, or like peeling a grapefruit. That could be someone who's had multiple biopsies. Doesn't always be the case. And you get normally what I hope for is kind of like peeling those two pieces of the fruit. Just kind of, you have that nice thin membrane on each side, one on one piece of the tangerine, one on the other. You don't kind of break into each other.
So it's not going to develop a scar tissue?
It may, but it's not necessarily the biopsy, because when you do the biopsy, two things can occur. You can get an infection, and you get the intense reaction, and you can also get a little bit of bleeding around it. So it's hard to say. And again, for the patients that I have done, it's not like, wow, I had to botch your nerves or I had to stop the surgery. No. But if someone did have a biopsy, I usually wait 2-3 months from the biopsy to doing surgery, especially if they want nerve sparing. Some with more aggressive disease, where that's not as important, we'll go take care of business.
So did you say before that the death rate of 6% has been improved because of PSA testing?
Absolutely.
There was a controversy that it did nothing to improve the death rate.
I beg your pardon?
There was a controversy about PSA testing.
I think you came in just before was my prelude, saying that the PSA, I could sit here and keep you guys till tomorrow morning and talk about 5 studies here, 3 studies here.
Yeah.
It's like a ping pong match. But the way I look at this, great. We know PSA is not great. It's not specific. It's prostate specific, but it's not prostate cancer. The same idea of mammography. It's not perfect. We miss things. We overdiagnose things. But what should we do? Just walk through the street and come in when you've got bone pains? I don't know. That's kind of the issue. But definitely, if you look at the curve over the last, you look at the Cancer Journal, they publish every year every cancer, survival, diagnosis, incidence reports. You can actually see the incidence since the PSA became effective in 81, well, we're picking up. So there's sort of a catch-up as we were finding the incidence. The incidence went up, but the survival, which as I said, it may take 10 years to show effect. Well, 10 years later, you actually see a drop in the slope of prostate cancer mortality.
So what do you do if your family doctor has read all these new studies and just say, don't need a new PSA? Go get it done yourself, change doctors?
I would ask them to get a referral to a urologist. You have that right. Besides, going back to let's break that question down. You asked me if my family medicine doctor read the literature.
Yeah, they do.
Okay, first of all, I like to shake that person's hand, because most people, I sometimes present this stuff, they're not even aware about this.
He quotes all the studies and all the
Well, you hold on to that GP then, and you tell everyone, it sounds like he knows.
Well, he does keep up with all the literature.
So
But
again, it depends on an individual basis. So he's telling you you don't need a PSA?
yeah,
And how old are you?
50.
Okay, again, controversial. I recommend it. I think at 50 your warranty's up as a human. No, but seriously, and one of my last slides, I kind of, to jump through my complications, outcomes, and all that stuff, just to jump to one of my things that I say that, let me jump to the end here, but one of the things I think is when you're 50, unfortunately, well, you should be screening not just for prostate cancer, but you need, as I said, your cardiac, you should, in a perfect world, I think you should have a stress test, because if you do an EKG,
He can
colonoscopy.
list all the studies on that too and say,
Absolutely.
You don't need it.
Okay, that's good. But you should say, doctor, I'd like to have it. You have that right. I don't know. I don't think he can suggest to you, but to people say, look, I want this, and I'm making a suggestion, and they don't have to take it. But it's a hard thing. I don't know, go to a private lab and do it yourself. I mean, I think it's important.
It does make it more difficult.
Yeah. Again, I don't know. Do a lot of people have that issue? Is that only this year, or is that only for you? And I'm asking other people, do other people have family doctors who say, don't do the PSA?
My doctor never did it. I'm having the operation at the end of the month.
To add to that, I have patients coming to see me for consultation, and they tell me that their doctor never did a rectal exam on them. So, again, going to something, I'm telling you what I'm seeing.
This is something he's changed. He does the rectal exam
Good.
previously, but now he no longer does it.
Okay. Well, there is the pivot study, and that was what came up in March, and that's what declassified the United States task force. But we're not in the United States, we're in Canada. If you all follow the CUA guidelines, we recommend it. So,
I think that's what he's reading.
good, and that's great, and again, it's a whole controversial matter. I can make points on both ends. I'd rather know, and I've actually, unfortunately, and again, this happens once or twice a year in my practice. I have a guy, 51 years old, came to see me, a little bit of blood in his urine. What I do for hematuria workup, he gets an ultrasound, we did a cystoscopy. Did the cystoscopy, found some fraudulent tissue. Did a little biopsy of it. My pathologist said, this doesn't look like bladder tumor. Check this PSA, 71. Bone metastasis. Again, what's the cost of getting a blood test? $2.90. The number may be mixed matter. Just one number doesn't make a difference. I always like to repeat, let's get a couple of PSAs. That's the changes that makes the difference. Had that patient, again, family history, didn't have a family history, but I mean, your heart goes up when you're like, wow, and I mean, that's a real punch to the head. Because at that point, bone metastasis, even with hormone therapy, you're looking at a survival sometimes of 7 years. He's 51. So, again, I'm not trying to scare people and so forth, but again, it's those simple things. To me, it's a simple thing. Yes, when you look at a population, and we're trying to save money in a country where we have a $23 billion deficit, well, okay, makes sense. But to me, it's like saying, you know what, we're not doing mammography anymore. Doesn't help. Okay, but give me something else that I can help to arm myself. And that's what I'm trying to do here, to at least arm you guys with some information that you can go, educated or, head off and ask more questions. Because I think that's what you need to do.